The Committee on Oversight and Government Reform, Subcommittees on Information Technology and Healthcare Benefits and Administrative Rules will get started again. I appreciate our witnesses and guests, patience as we went to go vote. We shouldn't be interrupted, and to get us restarted is my friend from California, Mr. Liu. You're recognized for 5 minutes.
Thank you, Mr. Chair. Dr. DeSalvo, in your opening statement, you mentioned data blocking. Can you explain what that is and how it works?
Certainly, Mr. Liu. Thank you for the question. Congress asked us to provide a report on health information blocking, which we did last April. And we thank you for that because it generated a national conversation and set into motion some actions that we've been taking in partnership, for example, with the Office of Inspector General, also with Office of Civil Rights, to see that we unblock data that has been collected in electronic health records. This is a new challenge we wouldn't have had years ago when we did not have a digitized system. It's emerged since 2009 when the HITECH Act put ONC and our authorities into place. An example of it would be that I'm a health system and my patient records have been collected or digitized, and my patient ends up in the emergency room at another hospital across the street, and for whatever reason I'm not sure I can share it because I don't understand HIPAA, or maybe don't have a business associate agreement that I think I need to have to share data. And so when that patient shows up across the street, literally, the data is not moving, and it's just because of a lack of understanding. So that would be sort of an unknowing example, and by educating about HIPAA, which is something we've been actively doing, we hope to unblock that sort of data. Sometimes it's more around business practice. People want to hold on to patients or hold on to data and don't share it. So we have asked and gotten pledges from the health IT industry to say they won't block data. Now we're acting on making sure that we can put some teeth to it. But if I may, Congressman, it's an area where since 2009 the world has really evolved, and that's why in our budget request, we did put forward a proposal asking for some more opportunities for us to be able to address blocking. And to see that where data could move, that it would. And we really welcome the chance to talk with you more about the ways that we think that we could have more opportunity to address it.
And just so I understand, sometimes you have data blocking because the doctor or hospital may not have interpreted HIPAA correctly. Are there times where, in your opinion, they're intentionally doing it to gain a competitive advantage?
We've certainly heard plenty of reports about the use of it to gain a competitive advantage.
And what about vendors? Do vendors sometimes do that as well?
Occasionally, the way that will occur with vendors is they'll require added fees, unexpected fees, to create the interfaces, and that is a form of lack of transparency, but also can be a form of blocking.
And in the high-tech law, do you believe there are gaps that could address this? And essentially, what can this committee of Congress do to help with data blocking?
Yes, sir. What we've asked for as part of our budget request is some additional opportunities around defining it, and giving us the opportunity to require that vendors, for example, can't use gag clauses to prevent providers from talking about some of the contractual elements. Those are just a couple of the examples that we've asked for. So yes, we do believe that since the world has evolved, there's a new need for us to have some additional opportunities to protect the people who are using the systems, and more importantly, to protect the data of the consumers.
Let me switch to cybersecurity. Hollywood Presbyterian Hospital in Southern California had been attacked with malware, and they had to give a ransom to get their data essentially unencrypted and unblocked. 2 more hospitals, it was disclosed, were recently attacked in Southern California. What do you think we can do to help prevent those attacks? And my understanding is that, is it the Office of Civil Rights that does the cybersecurity, and whether you think that would be the appropriate office or not?
The Office of Civil Rights does have the primary responsibility for privacy and security and for security breach investigations. We work with them in a variety of ways to see that we're educating providers, clinicians, and others to make sure that the functionalities, the capabilities in electronic health records that we require to keep the data secure are actually used in the field. We all know that there's a mix of both physical and cybersecurity expectations. So tools like our security risk assessment or tool is a way that we educate providers to know in a simple way how they can protect the data that's in there. So there are some opportunities that we leverage, but we work largely in partnership with the Office of Civil Rights.
And does that office have a team of computer folks that deal with cybersecurity issues?
It's a very tight partnership. They certainly have experts in the area of HIPAA and cybersecurity and privacy, and we work very hand in hand with them. We, for example, recently released some additional guidance for providers, but also for consumers about access and security, and have posted a series of joint blogs to make sure that there's a shared understanding of what security expectations there are. We work with them. You all, for example, asked the department to put together a cybersecurity task force, and we've been working along with others across the department to see that we put together that task force, and it just met for the first time last week, so we thank you guys for raising that issue.
Thank you. I yield back.
I'd like to pick up where Mr. Liu left off. So in OCR, so they have lawyers, because you said they understand HIPAA. Do they have technical folks that can actually help with a breach or when the next ransomware attack?
So, Congressman, I wouldn't want to speak specifically to the skill sets of their staff. What I can share with you is that the Office of the National Coordinator, which has technical staff, partners very tightly with the Office of Civil Rights, just like we do with other agencies, to make sure that we're bringing that talent to the table if it's necessary. Part of this task force, as an example, which is with the private sector, is to bring together the best minds in cybersecurity and to work with not only ONC, but OCR to see that we're helping to advance the healthcare marketplace to adjust to any new changes they need to in cybersecurity.
Ms. Rich, why is there so much confusion around HIPAA?
I can't speak to why there's confusion around HIPAA, but I do know that there's many entities that are outside of HIPAA that are under our jurisdiction, and that includes all the health apps and the websites that take in consumer-generated information. And that consumers may be confused about whether there is a regulation that protects their privacy in those areas, which is one of the reasons why we think there ought to be a regulation that protects the privacy and data security for the information collected by those entities directly from consumers.
Does FDA have responsibility in some type of regulation in this space?
The FDA regulates medical devices, and that includes some health apps, but generally they are looking at safety issues surrounding whether the app does what it says it does. The privacy and data security issues of such entities is generally in our care, and we have been working in this area for over 15 years, and we have an extensive program to look at the data security of these entities and take action, well, educate them to start with, and then also take action in appropriate instances.
So if it's a HIPAA violation, that's OCR's jurisdiction. If it's generally something else, it may be you, it may be FDA, it may be SAM, HSA, or the Patient Protection, PPACA. There's so many of these different regulatory bodies, and my fear is that it's hurting innovation. It's hurting the proverbial two guys or two gals in the garage from creating something that can change the way that we deliver healthcare. And Ms. Rich, I'll get back to you on another question. And I wanted to ask Mr. Quinn, Dean, Crescenzo, and Savage, and then Mr. Salvo, you answer after them. Meaningful use. This is a term that I've been hearing a lot over the last 16 months that I've been in Congress, and how it was originally designed to kind of spur companies from participating in EHR programs, but what I'm hearing is that it's actually getting in the way of innovation. I'd like for you three gentlemen to comment on y'all opinions on meaningful use, and Mr. Salvo, I'll let you be the cleanup batter. Mr. Quinn.
So meaningful use was quite successful in driving adoption of electronic health records. And without meaningful use, we wouldn't have the rates of adoption today that we see. As is the case with my dad's example, that each individual healthcare organization has an electronic health record and may be beginning to exchange data, doesn't mean that the net result of it is the coordinated care, the shared health information that we all need. And the prescriptiveness of this led some vendors and healthcare organizations to play to the test. What we need is to think ahead about the next generation of technology that's needed to embrace, for example, the Internet of Things, consumer-generated health data, the data that's being unearthed with the genome, and these other sources, and incorporate them into this so that we're not just thinking about this program as an end unto itself, but as an enabler of new technologies, new care models, et cetera.
Thank you. Sir.
Thank you, Mr. Chairman. I would certainly second Mr. Quinn's opinion that meaningful use, as it's been effective in the last few years to dramatically increase the use of EHRs, as Dr. DeSalvo mentioned earlier. In addition to some of the new technologies that he mentioned need now to be considered, it also suggests that over the last 4 or 5 years under meaningful use, we've learned a lot about how technology is used and what are some of the other process and incentive issues, and including things like reimbursement mechanisms that may or may not incent further use of electronic medical records and other types of electronic digitization of health information and the sharing around that. So going forward, we believe that we need to be thoughtful about what we've learned over the last 4 or 5 years as we look at additional regulation or requirements for expanding the use of electronic medical records and other allied technologies.
Mr. Savage.
So we agree that the Meaningful Use Program has been a major catalyst for improved adoption and use of health IT. And patients have been seeing a lot of the benefit of that. As I said in my testimony, there are still obstacles to overcome. More needs to be done. But with the Meaningful Use Program, in our surveys, we saw a doubling of online access from 2011 to 2014, from 26% of patients with online access to 50%. We see them using it for the kinds of things that are really critical for delivery system reform that is coming. So the access is as important, but the Meaningful Use Program is also set in 2018 to provide much more robust functions around patients sharing data with their providers, non-clinical data that is nonetheless relevant to care, better correction of errors, wearables, remote monitoring, and it will indeed stimulate the kind of innovation that we're all looking for. The version that's coming up also has APIs. We have tech developers who are writing apps for using those APIs. So important catalyst. Critical things are coming for patients and family caregivers to help them with their care planning.
Thanks to these folks, I'm just going to talk about the going forward because the health IT landscape and healthcare has absolutely been changing and evolving, and where we're looking to go forward after listening to providers, after seeing where the health IT landscape is to take the opportunity that was made from the doc fix or the macro legislation and make this program going forward more flexible, much more focused on clinical outcomes and on interoperability.
Thank you. Mr. Cartwright, you're recognized for 5 minutes.
Thank you, Chairman Hurd. I want to follow up that discussion with Mr. Savage a little bit. I think a cornerstone of the health IT field is the electronic health record, the digital version of a patient's paper chart containing not just the patient's current condition, but also his or her medical history. And I have here, looks like a poll, a Harris poll that MPWF commissioned. Is that correct, Mr. Savage?
That's correct.
All right, so this is entitled Engaging Patients and Families, How Consumers Value and Use Health IT. and I'll ask that this be made a part of the record, Mr. Chairman.
So moved.
So it's a Harris poll, it's a result of the Harris poll. I can't imagine how long this poll went, Mr. Savage, but it's pretty hefty. It was done in the spring of 2014, correct?
Correct.
And toward the end of it, there's a global summary, and it showed that more than 50% of patients want the ability to review their treatment plans, right?
Correct.
That nearly 60% wanted to see their doctor's notes, and that fully 75% of patients wanted access to their test results electronically. Have I got that correct, Mr. Savage?
Yes, we found great interest in all of those.
So that's the sort of information that would be available in an electronic health record, correct?
Yes.
Okay. Is it easy for patients to get access to their electronic health records right now?
The survey that you're referencing does identify increased numbers of access, so doubling from 26 to 50%. For those who have it, it has become easier, but the national partnership has also done work with the Get My Health Data campaign, which has found that there are also people without the access that they need, and that there are some barriers. So I can either talk about on the survey side, or I can share with you some of the barriers we found with the Get My Health Data side.
The barriers I'm interested in.
Okay. So we found we have tracers, volunteers who report to us their experience with trying to get data, and everybody's story is unique. But we do find some commonalities among those stories. So some of the significant barriers are a very complex, time-consuming process in order to get access. So you and I in order to get access to our banking records, we may just go down to an ATM or access it through the internet. That's not a time-consuming process for the norm, but for access to health records, yes, it's been very time-consuming for these individuals. Records provided in a format that's not useful, you may ask for it in electronic format, you get a piece of paper by snail mail, misunderstanding of what patients' rights to access are, and perhaps one of the things that we've discovered most recently is the use of unreasonable fees in order before you can get access to your record. So that may take the form of, you've asked for your information, sure, here's the copy and here's the bill, and it's a bill that you never expected, surprise. Or you're charged a per page fee when it's an electronic record. So there's actually been, the Get My Health Data campaign has recommended that there be some comprehensive education initiatives to try to help providers and patients alike understand the requirements better. And the OCR guidance that recently came out provide some examples of the kind of innovative education efforts that we really do need to see.
Dr. DeSalvo, pick up from there. What kind of examples?
So that consumers have more access to their information than they did previously, though it's not where we think it needs to be. And as Mr. Savage mentioned in his earlier comments, we've been pushing through the Meaningful Use Program and through other ways to get increased consumer access. We, in fact, just put out a challenge grant through the Office of the National Coordinator, calling on the private sector to take advantage of this API expectation that we've put in electronic health records to create very consumer-friendly apps that would be on a smartphone and allow any patient to be able to access their health information and have more opportunity to control it. So we're really excited to see what the private sector is going to develop in the next few months to make it easier to get more access. The kinds of examples that get in the way of that, not technology, certainly Mr. Savage mentioned, but they are sometimes just a misunderstanding of HIPAA. The congressman had asked earlier why doctors don't understand HIPAA, and it's part of it that we're not really well trained in it in medical school. This is I think a really important opportunity that the medical education field has along the way to see that we understand what HIPAA is and is not, and don't let it get in the way, though also the way sometimes it is enacted gets in the way of consumers having access to their information. It is, in essence, a form of blocking. And so again, back to this comment of the world has really evolved, and now there is data to be free, data to move, and the primary concern is to see that it's there for that clinical moment when you need it. But there's also many other important uses. So we're leveraging all the tools we have, whether that's education or clarity on rules and regs, but there's probably also some additional needed attention and maybe some additional supports to see that blocking is never a reason that people don't get their data.
So last question. My sense of it is that the better access patients have to their medical records, the better we all are in terms of patient safety. Does anybody disagree with that?
No,
Okay.
don't disagree.
Let the record reflect they're all shaking their head no, Mr. Chairman, and I yield back.
Thank you, sir. And now I'd like to recognize Ms. Lujan Grisham for 5 minutes.
Thank you, Mr. Chairman. I think I probably want to take off from where my colleague was leading you all, Mr. Cartwright. I actually think, in addition to the blocking and misunderstanding, that we've seen two principles in HIPAA be determined, and as an attorney, I feel bad about this, but sort of a legal opinion that you have two mutually exclusive premises. One, patient protection, and the other would be the portability of that information. And they err on the side, they are absolutely in their minds mutually exclusive, so they go to privacy. I just had this happen with a very large, very recently, healthcare provider who argued with me, which is, and HIPAA, I spent a lot of time dealing with HIPAA, so it wasn't I won. Because the CEO of the healthcare company refused to provide the patient information from provider to provider. And actually, I was trying to do him a favor, right? I've got labs that are 45 days out. I get a patient who calls my office as a constituent, says, I got to have them because my specialist can't do what they need to do without the records from this other provider. And I said, let me just call because I know I don't need really anything else. Provider to provider, just do it. And basically, I'm helping you because God forbid we find something in those labs that indicate to your lawyers that you have a real liability. And then second, they wouldn't do it because HIPAA prevents that, as you all know, absolutely does not. But for the audience, does not prevent that. It explicitly provides for that. And then in addition, to make it easy for them, I was willing to get the patient on the phone with plenty of patient identifiers. And then HIPAA, according to this provider, also explicitly prohibits not having someone where you have really restrictive proof that that's the patient. And I said, that's nowhere in there. That's your own system, which gets to that it's proprietary, it's not interoperable, and that while we're doing, I think, great strides to make this information available, that unless we deal with that, you can't really create a patient record. I'd have to have apps for about right now. Let's see, I'm old, so that would work with about 47 different providers. And now that I'm lucky enough to have this job, I have to add all the providers that are in DC that I guarantee you don't speak to any of my providers in Albuquerque. So. That was typical for me, long-winded statement that our intentions here and meaningful use and all the incentives and including many of the accountability mechanisms really haven't gotten us to what we really want, which is very effective patient records. Because if you want patients to be part of problem solving, and you do, if I get access to my record, I find all kinds of stuff that my docs didn't see because they're busy. I feel bad about that. I love them. They're my docs, so I really like them. Or my practitioners, but they don't have the time to search through stuff, and which is why every time you go, they got to do a whole new history because they got to ask me because it's much faster. But what happens when I am about 20 years from now? I can't remember for a whole variety of reasons. So, what additional incentives can we use? And give me, and you sort of floated around many, right? But I also want a milestone check. because I've also been working on telehealth for more than 2 decades. And quite frankly, the reimbursement issues and the other barriers really simply have not made it available in the places where the technology, not only in just physician-to-physician consultations or physician-to-patient consultations, but now you have the ability to do incredible online diagnostics. And yet, we aren't really doing it. So what are some really great milestones and mechanisms that this committee can help you achieve to that end? Anyone? All of you? Everyone?
Well, I'd like to just comment that I do think an obstacle to uptake on the part of consumers is concern about privacy. An obstacle to uptake of use of electronic records. Regardless of what a lot of consumers think about privacy in other contexts, we do know that they care a lot about privacy when it comes to their health records, which can reveal truly personal information. So from the perspective of somebody that's talking about privacy, we would like to see stronger protections that make sense. Yes, it's a balance. Stronger protections for data security.
Where do you see the balances so that, and nobody, I think, on this committee is making any sort of statement that we should reduce privacy protections. But when they become an obstacle for that does not diminish the protection of privacy, we have a really big problem here. And I gave you one illustration, there are many. But what's a milestone to not diminish the protections that we're all interested in, but to get us to real patient records, serious interoperability, not just provider to provider because of proprietary, but as you mentioned in an earlier meeting, within our hospital equipment, which creates huge patient outcome issues. That's not a privacy issue. And gets us to telehealth, all the different kinds of things I know that you all are promoting. And I don't know if the chairman's going to let me keep doing it. What a good guy. Can you talk?
Mr. Quinn can answer that question.
I would say a wonderful milestone is getting to 50% alternate payment models by 2018 as HHS has proposed, and that Intel, eating our own dog food, or as my colleague says, drinking our own champagne, including in Albuquerque, where we have a huge facility.
We'd like that to be bigger.
33,000 employees are today participating in our Connected Care program. And the real enabler of this is, of course, that there's something called the Sequoia Project that makes interoperability possible and connecting 150 different EHRs. But more importantly, that we are directly contracting with the providers in that area, and we have purchasing power. We're doing this in Albuquerque, we're doing it in Portland, doing it in Arizona. And Intel is a big purchaser, and we said, you're going to participate as part of this, and we're going to collect these metrics. The same is happening in this national basis as this 50%. 50%, I think, is a real tipping point, because you can't live in two different worlds. You can't live in the fee-for-service world and the alternate payment world. And the sooner we can get there, the better. We can't let up on the accelerator.
Okay, thank you.
Thank you, Mr. Quinn. Raise your hand if you have suggestions on how to harmonize privacy laws and which privacy laws and regulations need to be harmonized. No? Mr. Savage, y'all's organizations don't have opinions?
We do. We don't look at them as harmonization. We look at them as protecting privacy for patients in all the different states.
So I would like all of y'all to submit those ideas, those white papers, to the committee for the record so we can review those and see if that can be an area that we look at. And I would be remiss if I don't ask a cybersecurity question. And Ms. Rich, this is for you. And I'm not interested in any particular company or something like that. What do you think is the biggest threat right now to health information and our citizens' health data?
There's a few. One is failure by companies still to take this as seriously as they should. There's been a lot of progress in recent years, but we're still seeing not enough attention focused on this issue. Congressman Liu also mentioned ransomware, which is something that is on the rise and is particularly on the rise when sensitive information is collected because of the great interest in protecting that information, and so it's the ransomware tactics are more likely to succeed, and we're seeing that more and more in our cases, and we're looking at this issue ourselves and maybe doing something publicly on that. But the number one issue is still the failure to pay enough attention to this issue among many, many companies.
Mr. DiCrescenzo?
Well, obviously, Ms. Rich has her perspective, but I think at the HLC, we're taking this very seriously, and we see across providers, payers, pharmacies, everybody who's part of HLC, an enormous amount of investment and forward thinking on what to do about the problems that you described, for example, at Hollywood. I think one of the challenges that everyone needs to recognize is that we're also trying to constrain costs as much as is practical in the U.S. healthcare system, and all these things come at a cost, and there's not necessarily as much freedom, or maybe should there be, to be able to capture reimbursement in order to reflect those costs. So I think it's a very difficult area when you think of the resources that are applied anywhere from telecommunications to banking to other industries around cybersecurity. The fact that we've all described about the importance of personal health information and recognizing that many of these institutions, including many of the hospitals, I'm sure in your districts, are already struggling to deal with a number of other aspects of successfully providing patient care. So I think we certainly see people taking it very seriously, and as I'm sure you're aware, many people go into the medical profession because they have that commitment to patients, their data, and privacy. So I think one of the things we need to consider is how well is reimbursement reflecting the cost of doing a good job at it.
And Ms. Rich, what's been the biggest fine that FTC has issued on a private company for for violating our privacy? We don't need to know the situation, just what's the dollar amount? And can you describe the situation?
We actually, in the initial instance, don't have fining authority in the data security area in general. We do when it involves kids' information or consumer credit data. But in the general data security work we do not have the authority to obtain any penalties, and that is, I think, something that we seriously need in order to create different incentives here.
If a private company would have lost the information on 23 million records, what would FTC have done?
Well, in the abstract, it's hard to say. Each violation, if we had civil penalty authority just borrowing from the authority we have in other areas, every violation could be amount to a $16,000 penalty. So if you add that up over millions of consumers, it's potentially infinite, but of course we take the ability to pay, et cetera, into account. But the fines could be quite high for a company that had very serious violations and injured a lot of consumers.
Great, thank you. And now to close us out, Mr. Blum, you're recognized for 5 minutes.
Thank you, Chairman Hurd, for holding this most important hearing, and thank you to all the panelists today for your insights. Appreciate it very much. Telehealth, telemedicine has absolutely intrigued me since I've been in office the last 15 months. When we talk about rising healthcare costs in the country, I know many citizens want a silver bullet. You know, one answer, one thing's going to solve the increasing healthcare costs. And I kind of believe, and pardon my pun, but I believe it's been death by 1,000 cuts, the increase in healthcare costs. It's been a lot of small things. And I think one piece of the puzzle, the solution to keeping healthcare costs in line is telehealth or telemedicine. And particularly in our veterans care system with the psychiatric care with PTSD. I know in Iowa it's rural. So we don't have a lot of, in all of the outpatient clinics for vets, we don't have a psychologist or a psychiatrist on staff. So telemedicine is a great application there. I'd like to ask, all the panelists, what policy changes do you think are necessary so there's 100% telehealth participation by the providers and by the hospitals? Because I just see it as critically important to saving the government money and also improving the outcomes of our patients. So whoever would like to take that, jump on it, please.
Congressman, perhaps I'll begin and say that I share your enthusiasm for telehealth. As a doctor, have had the opportunity to use that, particularly for access to psychiatric care in my home community in New Orleans after Katrina, when we had really a lack of services. And as a rural state, we've been able to leverage that as well. As a care delivery model, very well received, can also save people money because they don't have to take off of work and find childcare, et cetera, to go to the sites. It's less of a technology issue and more of, I think, an opportunity as we move to alternative payment models. So as the VA has been able to show, and the private sector, and certainly through some of the work that the department has done with these models in the Center for Medicare and Medicaid Services, we've been working to advance that as an administration in partnership with the private sector. I think it's something that we see as a department, an opportunity in the delivery system reform work that's moving to alternative payment models, such as in the macro legislation that's required for docs. It's going to give us a lot of opportunity to really enable and support new kinds of care models. So from our standpoint, we believe that with the department, we really believe that we're moving forward into this world, and that the macro legislation for docs in particular is going to be helpful.
Since you're a medical doctor,
Yes.
correct? And I know you can't speak for the medical community, but what's your impression or your opinion of the medical community's opinion of telemedicine? I mean, is it a good one, or do they say like, this isn't that good of stuff?
So I can't speak for the medical community. So
Admittedly.
I'll speak for myself and my peers that there are some real benefits to it. Speaking purely as a doctor, I think one of the challenges is there's a lot that you gain from being in the room with a patient. You can touch them, you can listen to them in a way that you can't necessarily through technology. So a mix of kinds of interaction is typically what we want. We wouldn't want it to all be remote, because you also gain something from that touch, in that exam room.
Others would like to? Yes, sir.
Congressman, one other thing I'd mention is harmonization of standards across the states. Obviously, with telemedicine, as you described, it's something that brings the ability to provide care across a distance. And of course, many of the states are quite large, so it's urban to rural and various other ways that certainly would facilitate the growth of telemedicine in a very important fashion. But in addition, there's quite a patchwork of regulations and standards on a state basis across the country. So the ability to leverage perhaps highly specialized care outside the state is often more difficult for somebody looking to put together a national network, or even nationally focused providers like Cleveland Clinic and others who have a very large footprint across the country.
And what would the solution to that be? Is there an easy one? Or I like easy solutions.
Yeah. Well, we have 50 states, so I doubt there's an easy one. But I think there is increasing, I would say, similarity between the regulations in different states as they become more familiar with this. And perhaps like a lot of the work ONC and others have done around harmonization of technology standards, we would hope that also be a similar effort to harmonize the standards and regulations around telemedicine.
Yes, ma'am.
The FTC in the competition area, which I don't personally work, but we've done a good deal of work on breaking down barriers to competition that may hold back certain alternative forms of medicine. And for example, we've commented to states that may have laws that favor certain medical techniques over others, and in a way that interferes with competition. Through state laws. So competition is very important in this area.
Do I have time for one more question, Mr. Chairman? What are the major barriers that are preventing a focus on home-based health care versus expensive hospitalizations? It's another area I am very interested in, is keeping that person in their home as long as we possibly can, or getting them back to their home as quick as we can. Thoughts on that?
Well, I would jump in and say that that's a good illustration of perhaps an interoperability issue. We want to make sure that the patient's home is connected with the systems. So you want access. You want the patient to be able to send remote monitoring information to the doctor's clinical record. These are things that are actually in process of being developed on a national level. That kind of two-way communication between the home and the doctor's system also contributes to care planning. so that you actually have working together to manage the care and to move from care to health.
And this could apply to nursing homes as well, correct?
That's correct.
So I would say that one of the things that really is lacking today is ensuring that those home-based applications have a market. So today, without the reimbursement for many of those things, the market hasn't blossomed the way that it could. And many of the applications and the tools aren't necessarily designed for a 78-year-old or maybe someone with disabilities who's at home, and ensuring that that frankly, consumer marketplace with the technology that's rigorous enough to be trusted and incorporated into the healthcare system is built, and that there's a marketplace for it because there is reimbursement, there is a path for investors to say there's something here.
That's a good point. Thank you very much for your input. I appreciate it very much. And with that, I yield the time I do not have.
I'd like to thank Mr. Liu and Mr. Cartwright for the bipartisan nature of working on this topic. It's important for an exchange of information. I appreciate our witnesses for taking the time to appear before us today and for your patience. And if there's no further business, without objection, the subcommittees stand adjourned.